Hello, and welcome to our presentation on the final rule for the 2022 MIPS program. If you're having any issues with the webinar, please chat with us in the window at the bottom right of your screen. You have entered the meeting muted. Please ask any questions via chat due to the size of our audience today. We'll be answering the questions in the chat throughout the presentation, and we will also go over remaining questions at the end of today's call. My name is Randy Marsden, and I am the president of Marsden Advisors. This presentation is targeted at small and medium-sized ophthalmology, optometry, dermatology, and plastic surgery practices that report in the MIPS program. Since we are focusing narrowly on these specialties and that participation option, please consult the QPP site for a full list of changes. Also, a note that we are on YouTube. A copy of today's presentation will be available on our YouTube channel, and we'll be sending out an email after today's presentation with a link to that. We recommend that you subscribe and click the bell icon so that you can get any updates on any future webinars, as well as review our past ones. Just a quick statement that we're providing this for informational purposes only, and this doesn't constitute legal, financial, or medical advice. If you're new to Marsden Advisors, welcome. Most of our team got our start working for EHR software companies, and we launched our MIPS Success program in 2016 to prepare for the major QPP changes that are confusing to both vendors and practices. We currently support over 200 practices nationwide, consisting of over 1,200 individual clinicians, and we take the technical and training aspect of MIPS off their shoulders. Besides MIPS, we also help practices in migrating between EHR systems and optimizing the use of your EHR.
I'd now like to introduce you to Jessica Peterson, our VP of Health Policy, to take you through today's presentation. Take it away, Jessica.
Thanks, Randy. Today we're going to go over the top final changes to the QPP for 2022, including changes to the 4 categories: quality, promoting interoperability, improvement activities, and cost. Of note, our presentation is focusing on the specialties we have the most clients in: ophthalmology, optometry, dermatology, and plastics. If you need further information that is specialty specific for you, do feel free to reach out to us at info@marsdenadvisors.com. We're also going to go over the rulemaking process and commenting and how we help practices succeed. Let's start with a quick overview of MIPS and the high-level final changes to the MIPS final score for 2022. Today we're going to talk about the QPP, or the Quality Payment Program. This was established by the Medicare Access and Chip Reauthorization Act of 2015, or MACRA for short. This was a fantastic law in that it finally ended the Sustainable Growth Rate Formula, or SGR. This was what was responsible for Congress having to pass those doc fixes every spring to avoid a 20 to 30% across-the-board pay cut under Medicare, so it was a huge win. But it also established the rules for the road for what Congress termed value-based care, establishing the QPP. There are 2 tracks for QPP participation. One is through advanced alternative payment models. These require you to take on financial risk. These are also pretty hard for specialists to get involved in, as there are few models that allow for specialty-specific measurement. So what we're going to focus on today are the changes to the fee-for-service track of the QPP, which is MIPS. So changes to thresholds and penalties for 2022. On this slide, we have the thresholds and penalties for 2021 on the left, and the thresholds and penalties for 2022 on the right, with the changes highlighted in yellow. As you can see, the threshold to avoid a penalty for 2022 has increased 15 points from 60 points in 2021 to 75 in 2022. Anything below 75 and you're looking at getting a payment penalty, up to 9%. Anything above 75 points and you're going to get that orange X% bonus you see on your screen. This is the budget neutral bonus. It's determined on a linear sliding scale, so the better you do, the more you get. But also, as I mentioned, it's budget neutral. And what that means is all of the bonus monies from that year come out of the pool of penalty monies for that year. So the amount that you get also depends on how many people are penalized and by how much. The exceptional performance threshold has increased 4 points from 85 in 2021 to 89 in 2022. anything 89 and above, and you'll get that green Y% bonus you see on your screen. This is the exceptional performance bonus, and it comes from a pool of $500 million that Congress sets aside for this purpose each year. It's also determined on a linear sliding scale, so once again, the higher you score, the more bonus you'll receive. But as it comes from a fixed pool of money, the amount that you receive is also determined by how many people receive 89 and above. Important note, the 2022 performance year, 2024 payment year, will be the last year that the exceptional performance bonus is available. After that, MIPS will only have the budget neutral bonus available. So 2022 is your last chance to take full advantage of this bonus. Now, how you're scored under MIPS hasn't changed significantly. The only big change is that CMS finalized a change to reduce the quality category weight by 10 percentage points, from 40% to 30%, and to move those 10 percentage points over to cost, increasing that from 20 to 30% of the MIPS final score. This change was required by law, and there are no other changes required by law at this time. So unless there is a future change to the law, there will be no future changes to the standard category weights under traditional MIPS. Now, there is a new exciting policy that was finalized and begins in 2022. It's a separate category reweighting policy for clinicians and small practices. Specifically, this new policy redistributes less weight to the quality category when promoting interoperability is reweighted. This is to help limit the amount of weight that's distributed to the quality category for small practices, because small practices have fewer resources and less ability to do well on quality than do larger practices. So this recognition by CMS will make MIPS more of a level playing field for small practices moving forward. Now, a new track for QPP participation that you may have heard of are the MIPS Value Pathways, or MVPs. This is a track that CMS has established. Per CMS, MVPs allow for a more cohesive participation experience by connecting activities and measures from the 4 MIPS performance categories that are relevant to a specialty, medical condition, or episode of care. The MVPs include promoting interoperability and population health claims-based measures as foundational elements, meaning that they'll be part of any MVP that's proposed or established, along with relevant measures and activities for quality, cost, and improvement activities, performance categories. Although the first year for MVP participation was meant to be 2022, CMS has finalized a delay in its implementation to the 2023 performance year to account for continuing difficulties caused by COVID-19. Now let's move into the category-specific changes, starting with the quality category. Some quick basics on the quality category. The quality category performance period remains full year, and the category itself remains out of 60 points. You must submit at least 6 measures, including 1 outcome or high priority measure, just as in previous years. However, as mentioned previously, the quality category weight will decrease to 30% in 2022, down 10 percentage points from 40% in 2021. There are also some major changes to the available bonus points that were finalized for 2022. Although the small practice bonus and the category improvement bonuses remain, both the end-to-end electronic reporting bonus and the additional outcome or high priority measure bonus, beyond the required 1 outcome or high priority measure, both of those bonuses have been discontinued beginning with the 2022 performance year. CMS also finalized some major changes to how quality measures are scored, beginning with measures new to the MIPS program. Starting in 2022, as long as both data completeness and case minimum requirements are met, any measure that's new to the MIPS program will have a 7-point floor in its first year of use. That means that 7 out of 10 points will be the lowest you'll be able to score for that measure. In addition, any measure new to MIPS in its second year in the MIPS program will have a 5-point floor. That means in the second year in MIPS, the lowest possible score you can get on that measure will be 5 out of 10 points. This is a huge win, particularly for specialties and subspecialties with few germane measures, as this will make reporting on new measures significantly less risky and will lead to these measures getting benchmarked. Getting enough clinicians and groups to report on new measures has been a significant hurdle in getting new measures benchmarked since MIPS began. So again, huge win. For all other measures, so all non-new measures, there are no changes in 2022 for how they'll be scored. But beginning in 2023, CMS finalized a policy to remove the 3-point floor on measures reported by larger practices, so practices with 16 plus clinicians. For small practices, so 15 or fewer clinicians, the 3-point floor will remain. Speaking of benchmarks, CMS did not finalize any changes to how 2022 quality measure benchmarks will be calculated. So, as in previous years, the data from 2 years prior to the performance year, in this case the 2020 performance year, will be used to calculate the measure benchmarks. And on the bottom of this slide, we just have an example of an ECQM benchmark. In case you're unfamiliar with what benchmarks are, it just goes through what performance rates are required for how many points out of 10 for the measure. And the benchmarks you're seeing here are from 2021 because the 2022 benchmarks have not yet been released. Now, CMS has also finalized the addition of 4 new measures, including one administrative claims measure: clinician and clinician group risk-adjusted hospital admission rates for patients with multiple chronic conditions. It's quite a mouthful, but long story short, this is unlikely to impact our specialties. However, if you are a specialty practice, but you also have NPs or PAs, you might get picked up in this administrative claims measure, similar to the TPCC or total per capita cost measure. In addition to this administrative claims measure, CMS has finalized substantive changes to 87 measures, 9 of which are so significant that the measure will no longer have a benchmark in 2022. All of our commonly used 2021 benchmarked measures will, however, have a benchmark in 2022 from current data available. Finally, CMS has finalized the removal of 13 measures, including 3 of our commonly used measures. We'll go over the measure changes in the coming slides for the measures that are most likely to impact our clients. I'll now hand it off to our wonderful team of MIPS Success Associate Directors to take you through these top measure changes. Take it away, Kate.
Thanks, Jessica. I will be reviewing the measure changes for ophthalmology, optometry, dermatology, and plastics. Beginning with ophthalmology and optometry, starting with measure 14. This measure is being removed from claims-based reporting as it has been topped out for 3 consecutive years. A measure is considered topped out when the average performance rate is 95% or greater. CMS did not finalize the proposed removal of measure 19, diabetic retinopathy, communication with the physician managing ongoing diabetes care. It will continue to be available via ECQM and MIPS CQM in 2022. For measure 117, CMS finalized a clarification that the patient must have an active diagnosis of diabetic retinopathy during the measurement period or be a diabetic with no diagnosis of retinopathy during the performance year. The timing of the diabetic retinopathy diagnosis has been a point of confusion for several years, as the wording used to state that the diagnosis had to be overlapping with the measurement period. CMS also finalized their proposal to allow exam interpretation to occur via AI rather than only being conducted by an ophthalmologist or optometrist. Finally, CMS will exclude any patients who receive palliative care during the performance year from this measure. Lastly, Measure 191 has several finalized changes, including for all collection types, the removal of the denominator exclusion for episcleritis. Also for all collection types, the addition of denominator exclusions for those with homonymous bilateral field defects and generalized contraction of visual field. For ECQMs, the addition of denominator exclusions for those with visual cortex disorders and inflammatory disorders. and for MIPS TQMs, the addition of denominator exclusions for those with sector or arcuate defects, other localized visual field defects, and heteronomous bilateral field defects. For dermatology and plastics, there are finalized changes to 4 measures. CMS did not finalize their proposed removal of Measure 137, Melanoma Recall. This measure will remain available through MIPS CQM in performance year 2022. Unfortunately, CMS did finalize the removal of Measure 337, Psoriasis TB Prevention. CMS finalized changes to Measure 176 that broaden its denominator by including an expanded list of biologic therapies that capture much of the denominator patient population for this measure. CMS states that these changes make Measure 337 duplicative of Measure 176. For Measure 176, TB screening prior to first course of biologic therapy, CMS finalized their proposal to revise the denominator instructions to specify that patients are considered to be receiving their first course of therapy using a biologic disease-modifying anti-rheumatic drug, or DMARD, and thus to be eligible for this measure only if they are prescribed a biologic DMARD during the performance year and have not been prescribed DMARD biologic therapy in the 15 months preceding the encounter, where any DMARDs were newly started. CMS also finalized their proposal to expand the denominator to include 4 additional biologics, as listed above, to align with current therapies. For Measure 265, biopsy follow-up, CMS finalized its proposal to update the denominator to clarify that only new patients should be included in this measure, and if multiple biopsies are performed for the patient, only the first biopsy should be used for the purpose of this measure. Finally, CMS also finalized changes to Measure 397, melanoma reporting. In order to align with updated AAD guideline recommendations, CMS expanded what is required information for pathology reports to also include the peripheral and deep margin status and presence or absence of microsatellitosis for invasive tumors. In addition, CMS clarified how to handle instances in which multiple samples are included in one report. In these circumstances, each eligible specimen on the report must include the required information, or performance in that instance will be considered not met. Since we also report some general measures for our specialties, we have listed those here. If you happen to use any of these measures as well, check our guide that was sent along with the initial invite to this call. We will also send a copy along with the recording of today's presentation later today. I'll now hand you back over to Jessica to take you through promoting interoperability.
Thanks, Kate. Now we're going to go over the final changes to promoting interoperability, the EHR category of MIPS. Some quick basics on PI in 2022. PI still has a 90 consecutive day reporting minimum, just like improvement activities, although the 2 categories can be performed on 2 different 90-day periods. There are now 115 available points in the category, up from 110 due to the addition of a new bonus measure, but the category itself remains out of 100 points. PI is also still worth 25% of your MIPS final score, and importantly, just as in 2021, you must submit an attestation or numerator of at least 1 for all 6 required measures, or be able to claim an exclusion for those measures, or you'll get a 0 for the entire PI category. Now, before we get into what the measures are for 2022, I want to let you know that there is one important change to the PI hardship exception policies. CMS finalized a new policy beginning in 2022 that all small practices, that's practices of 15 or fewer eligible clinicians, will have the PI category automatically reweighted unless they choose to report any PI data. This is quite exciting as it will reduce the work and tension for small practices that struggle with this category. That being said, given the difficulty many small practices have in finding germane benchmarked quality measures, we encourage practices that find they are able to reliably do well in this category to continue reporting it going forward. For our clients, we'll do an individualized analysis and conversation to determine the best course of action to fit your practice and your goals. So now on to the 2022 final PI measures. If you do report PI in 2022, this is what you'll be evaluated on. There have been no changes to the first three objectives. Importantly, CMS did not finalize its proposal to require information to remain available indefinitely, beginning with date of service January 1st, 2016, for the Provide Patient Electronic Access to their Health Information measure. This is pretty exciting because it would have been quite burdensome, and it's something we'll keep an eye on moving forward. However, CMS did finalize significant changes to the public health and clinical data exchange objective. So that's what we're going to go over now. Specifically, rather than requiring you to submit an attestation or exclusion to any of 2 of the 5 registry types beginning in 2022, CMS will now require you to either claim an exclusion or attest that you are in active engagement to submit data to both electronic case reporting and the immunization registry measures. CMS has made this change in response to the COVID-19 pandemic to improve future pandemic responsiveness and preparedness. However, there are exclusions available for these measures. The 4th exclusion you see on your screen is new. The others are the same as previous years, and it's for electronic case reporting and only in 2022. This exclusion states that if you're using an EHR that's certified, that isn't certified to the electronic case reporting certification criterion prior to the start of the performance period you select in 2022, then you can claim an exclusion for that measure. This will only be available in 2022. Now, if you claim an exclusion on both of these measures, the 10 points that these measures are worth will be redistributed to the Provide Patient Access objective, making that objective worth 50 points. In addition to the changes that made those 2 measures required in this objective, CMS also finalized 5 new bonus points that will be available under this objective. If you're able to attest being in active engagement to submit data on any of the remaining 3 measures in this objective, you'll receive the 5 bonus points. You can't receive more than 5 bonus points, though, regardless of how many additional registry measures you attest to. You only get 1. In the final rule, CMS also made one important clarification. They clarified that you will be able to claim the 5 additional bonus points for attesting to one of these 3 registry measures, even if you claimed exclusions on both of the required measures. So that's it for the measure changes for 2022. But in addition to the required measures, there are attestation statements. There are 5 attestation statements that will be required to get a PI category score in 2022. Most of these have been around for a while and are unchanged, but the prevention of information blocking attestation has been modified for 2022, and CMS has finalized a new attestation statement requiring annual Safer Guide self-assessment. Starting with the prevention of information blocking attestation, CMS finalized a reduction in the content of this attestation statement. Beginning in 2022, CMS will eliminate attestation statements Part B and C to reduce confusion or potential conflict between the attestation statements under PI and the ONC information blocking regulations. So it's a pretty minor change as far as whether or not you'll be able to check the box and say, yes, you are preventing information blocking, but important to note. The bigger change to the attestation statements is the implementation of the new Safer High Priority Guide self-assessment attestation statement. So, CMS finalized the addition of this new attestation statement in light of the significant increase in cyber attacks against the U.S. healthcare sector, particularly since the beginning of the pandemic. This includes against hospitals and independent healthcare practices. The Safer High Priority Guide self-assessment is 32 pages long. It seems like a lot, but although this measure would increase burden on healthcare practices, CMS believes that completing an annual self-assessment will help practices to prevent significant data breaches and data loss, potentially saving each practice the significant time and expense related to recovering from a successful cyber attack. Now, although 32 pages is a lot, once you've done your first, you can just go back and update it, kind of similar to the security risk analysis that you do every year. Of note, CMS states that the self-assessment does not require an organization to confirm that it's implemented fully in all areas, each practice described in a particular SAFER guide, nor will an organization be scored on how many of the practices the organization has fully implemented. Rather, the intent of this requirement is really for MIPS-eligible clinicians to just regularly assess their progress and status on important facets of patient data safety. In the final rule, CMS made another important clarification, and they clarified that for 2022 only, all that matters for your PI score is responding to the attestation statement. Even if you attest no to completing this self-assessment, it will have no impact on your PI category score. But this is, once again, only for 2022. Starting in 2023, you're going to have to check the box for yes. So that's it for PI. Not a ton of changes there. Now let's move on to the improvement activities category. Some basics on improvement activities. 90 consecutive day reporting minimum, just like in previous years. You can earn up to 40 points within the category. And it's still scored the same way it was in previous years, with the high priority, medium priority measures, and the double weight for small rule and HPSA practices. So basically, there haven't been any major category level changes to the improvement activities category, and it remains 15% of your MIPS final score. CMS has finalized changes to two of the improvement activities that are commonly used by our clients. Provide 24/7 patient access and engagement of new Medicaid patients in follow-up. The change to the 24/7 patient access measure is really minor and shouldn't really impact our clients. The changes to the new Medicaid patients in follow-up activity are much more substantial. First, CMS has changed the name of this activity. It is now Enhance Engagement of Medicaid and Other Underserved Populations. Second, this activity, as reflected in the title change, will no longer be limited to Medicaid patients alone. Clinicians using this activity can now choose to evaluate the engagement of other underserved populations if it's more appropriate for their practice. Finally, CMS has removed the timeliness requirement, which used to require an appointment within 10 business days of an appointment request. They've replaced this requirement with a new requirement to create, quote, improved responsiveness of care, end quote. This is to be measured using time to treat data. In addition to these changes, CMS added 7 new improvement activities with a heavy focus on wellness and health equity. The list includes improvement activities such as create and implement an anti-racism plan, which is high-weighted, promote clinician well-being, also high-weighted, implement food insecurity and nutrition risk identification treatment protocols, medium-weighted, implementation of a trauma-informed care to clinical practice, also medium, and implementation of a PPE plan, also medium. Although these might not be applicable to your particular practice, I mention these ones specifically because they're fairly broadly applicable to various practice situations and specialties. So that's it for improvement activities. It's time to go over the 2022 changes to the final MIPS performance category, the cost category. Quick basics on the cost category. The cost performance period remains full year, but as usual, it's all passive reporting as CMS calculates your score on the back end using your administrative claims data. The number of points available in the category depends on how many measures you're eligible to be measured on. Each measure is worth 10 points, so if you're only eligible under one measure, your total cost category score will be out of 10 points. If you're eligible for 2 measures, it will be out of 20, and so on. And as mentioned previously, the cost category weight will increase to 30% in 2022. This is up from 20% in 2021. CMS has finalized the addition of 5 new episode-based cost measures beginning in 2022. Of note, episode-based cost measures represent the cost to Medicare for the items and services provided to a patient during an episode of care. For these measures, cost is generally defined as the standard Medicare allowed amount, which includes both Medicare and trust fund payments and any applicable beneficiary deductible and coinsurance amounts. So to sum that up, it's what Medicare pays you and what the patient pays you for that service or item. There are no changes to the cataract cost measure for 2022, and most specialists remain removed from the total per capita cost measure. As with last year, NPs and PAs and practices with NPs and PAs that group report are subject to the total per capita cost measure. Of the new episode-based cost measures, the two we considered at the time of the proposed rule to be most relevant to our clients were the diabetes episode-based cost measure and the melanoma resection episode-based cost measure. After the publication of the final rule, CMS clarified that in order to be attributed the diabetes episode-based cost measure, you must prescribe 2 or more condition-related Part D medications to 2 or more patients. The clarification that these must be the Part D medications removes most of our clients from this measure, so we won't go over it here. But if you want more information on who will and won't get picked up under this measure and which Part D medications are considered, quote, condition-related, we'll include a link to our recent blog article on this topic in an email with a link to the webinar recording later this week. On to the melanoma resection measure. This measure evaluates risk-adjusted costs to Medicare for patients who have an excision to remove a cutaneous melanoma, including an eyelid melanoma. This measure is triggered when a CPT code indicating melanoma resection by removal of malignant growth, adjacent tissue transfer or rearrangement procedures, or tissue transfer repair of wound is billed. The code must also be accompanied by an ICD-10 diagnosis code for either malignant melanoma of skin or melanoma in situ. And then CMS will evaluate the cost of services that are clinically related to the attributed clinician's role in managing the care during the episode. If you have any questions on this, please email us at info@marsdenadvisors.com, and we'll have that email later on as well. So that's it for the 2022 MIPS changes, but how did we get here? We got here through the rulemaking process. It's not the most interesting sounding thing in the world, but it is super important. Each year, CMS releases a proposed rule for the upcoming calendar year of MIPS. These rules are really long, but we at Marsden Advisors always make sure that we have a summary article available online on our blog and to our clients when the proposed rule is released so that you know what the big changes or the big proposed changes are. The public has 60 days to comment on the rule, which can be done at federalregister.gov. And importantly, CMS can't finalize anything that they didn't propose, and those proposals are open for public comment. CMS really does pay attention to what people say in their comments, so if you do submit a comment on something that you see that we've written about in our blog or our emails to our clients that you're not okay with or that you're really excited about, it's a great idea to submit a comment to CMS so that they know how you feel about it, because that can actually influence whether or not it gets finalized. Because these comments are then reviewed by CMS and accepted changes are incorporated into the final rule. I can't stress enough how much these comments really do make a difference. So consider commenting next time we have the rulemaking cycle. We'll keep you updated. Now I'm going to hand it back to Randy to go over our services.
If you're not yet using our MIPS Success Plan, we wanted to provide you with some additional resources. So if you're continuing to do MIPS yourself, check out our ValView MIPS Estimator, available at mipsestimator.org. This can help you track your performance within your EHR registries and helps you produce a pending estimated score to determine how you're performing throughout the year rather than waiting till the end. We will be updating this system to include some more advanced features to help you identify your eligibility and to compare the ROI between individual and group reporting. As we mentioned before, this recording, as well as our past and future webinars, are also available at our YouTube channel with the short link there available for you to subscribe and receive notifications. If you'd like help in your MIPS reporting for 2022, we have a team of dedicated client success managers, including Kate, who spoke on today's call, that helps practices alleviate the burden of MIPS. We are still accepting clients for 2022 reporting. We're no longer accepting clients for 2021. Pricing starts at $900 per full-time provider per year, and we'll include more information on this program if you're interested in the recording email. Also, if you have any additional questions that weren't answered on today's presentation, they can be sent to ehrsuccess@marsdenadvisors.com. I'd like to thank you for joining us today. We hope this information was very helpful to you. We're now going to take a moment to look through the chat and see if there are any important questions that we wanted to discuss on the call.
All right, so we had one in the middle of the call from Alexandra, and I'm sorry, Alexandra Gieb. It was a question about the cost measure for diabetes. So the question was, if I'm reading the spreadsheet correctly about triggers, if we bill an E&M, but do not bill any CPT from the chronic condition CPT codes ever, and don't bill another E&M in 180 days, does that mean that we don't need to open a trigger episode and won't have costs associated? So if I'm reading what you're writing, that does sound correct, but it's also about how many people with diabetes that you treat. Now, importantly, as Randy mentioned during the webinar, you have to do at least two condition-related medications to 2 patients during the performance year. Now, condition-related medications used to be very broad, but now it's very specific, and that is only Part D medications. And it includes things such as insulin preparations, lisinopril, other blood pressure meds, and so forth, but it doesn't really include anything that you would administer in office or anything specific to diabetes complications. So it's unlikely that any of our clients would get picked up on this measure, but if you have any further questions or any further clarification, let me know. And I also did enable the ability for you to unmute yourself. So if you want to type question in the chat, that's available, but if you want to unmute yourself and ask verbally, that's available as well. While we're waiting for questions, we have Kate and Renee on the call. We could go over some commonly asked questions by some of our clients. Thank you, Deborah. I just saw your note. I appreciate it. Kate, Renee, do you have any commonly asked questions that would be changing now that we're moving into 2022 versus 2021 that you'd like to go over?
Hi, this is Renee. One of the things that I've talked about more recently with several practices since the ruling was released is about small practices reporting on promoting interoperability, especially as a result of the automatic reweight. Because of all the changes in quality, and Jessica, you can expand on it a bit, but because of all the changes in quality and some of the point value reduction, I've been talking with them about that we may need to report on it because of the point value changes for quality. So if you wanted to expand on that a little bit, because obviously the timing of having the weight coincides with quality being a little bit harder to score, like kind of a default scoring really well.
Yeah, absolutely. Thanks, Renee. That's a great question to bring up. So one of the things that we do for our clients is we do an individual evaluation of whether or not reporting for PI will be beneficial for them. If it's going to cause burden, how big is that burden? How much does it matter for their MIPS final score? So next year, all small practices automatic PI reweighting unless they report PI data. So a lot of people are like, great, I'm done. I don't need to report PI. But one of the things that we do mention to them, as Renee said, is quality is getting harder. It's getting harder every year. And the number of germane measures available for specialists keeps decreasing. We don't have the benchmarks for next year's quality measures yet, but when we do, we'll be able to provide more information for your specific practices based on the measures you've historically used and what measures could be available based on your practice patterns. And as we follow your performance throughout the year, we can give you updated evaluations at your quarterly updates or your monthly updates, depending on what plan you're on. And if you have any questions and you're not currently a client and you're curious about learning more, feel free to email us at info@marsdenadvisors.com, or you can just reply to the follow-up email when we send you the recording. But yeah, basically it is getting harder and harder to do well in quality. PI is not graded on a curve, which is why if you find it's something that you can reliably do well on, it's something I would consider doing in the future.
Jessica, Kate and I have another common one, if you can expand on it, is that we report on several non-benchmark measures, and then we go through the explanation about after the data submitted and if it does get benchmarked, and especially for next year in light of quality losing some of those bonus points, if you want to expand on that a little bit more.
Yeah, sure. So as we've mentioned, the number of germane quality measures, especially for specialists, is going down every year. It's part of what CMS calls their Meaningful Measures Initiative. So they're trying to cull out measures that they don't think there is room for growth on. So measures where they're all topped out, they've got very high performance rates, or they're just check the box measures. But the side effect is, we don't have enough measures to report on as specialists. Part of how people have been trying to fix this is by creating new measures, especially QCDR or registry-based measures. A problem with this is in the past, those measures, the most you could get on them, unless they were what's called retroactively benchmarked, was a 3 out of 10. So a retroactive benchmark means that enough people reported on those measures for enough patients that the measures had enough data to be benchmarked based on the data from the performance year. So that's why we try to get our clients to report on some of those unbenchmarked measures, because there are measures we anticipate losing in the future. Even if we didn't lose them this year, next year, it's pretty likely if they were proposed for removal this year and they didn't get removed, they'll probably be removed next year. So we want to make sure that we have a growing bench of measures to fall back on as we move forward. So even if the measure doesn't count toward your performance score for the quality category, by reporting on that extra measure, you're giving CMS data to create a benchmark to deepen your bench of existing measures should more measures get culled from the program. All right, so I'm not seeing any additional questions in the chat. So I think we can give everybody a few minutes back today. Again, feel free to email us at info@marsdenadvisors.com. We're happy to answer any questions that you have. We're also going to be sending out an email sometime this week with a recording of the presentation and any links that we mentioned during the presentation. So you can just reply to that email as well. Thank you guys for coming. We hope this was informational. And again, if you have any questions, we're happy to answer.